Hi, everybody. Welcome to the Pelvic Health Explorers interview. I'm excited to be able to be sitting here across the country, but on the same screen, sharing a place with the amazing Kathe Wallace. And she is lending her time and her expertise to us today to talk about some great clinical issues and pearls around prolapse. So, Kathe, tell us a little bit about yourself, and then we'll launch into some of the information you're going to share today.
Oh boy. Well, I'm currently spending quite a bit of my teaching time in the prolapse and pressure realm. Um, I am working some with students at the University of Washington doing some independent studies. I'm really excited about making and helping people use their physical therapy skills a lot in women's health. I think sometimes there's like this transition, like, oh yeah, let's look at the whole body, the whole picture, and the whole person. And um, I just hope to kind of talk a little bit today about some of the key anatomy things that I think are important, and a few ways to look at prolapse that is more than just how far it's descending. So I'm here for you.
That's amazing. And one of the big things we talk about in the membership is that we have to look integratively at the entire person, that it is not a regionally specific um, parameter, which is why I love the transition to the world of using terminology such as pelvic health and getting away from like a muscle specific type of thing. So anyway, yep, you're singing a song that I love to sing myself, so we can harmonize together beautifully.
There
So
you go.
let's get rolling. I think one of the first things we can talk about is what are the key anatomical considerations of an exam?
Hmm. So I'm going to be talking about a vaginal examination. And I think that as we're looking at our patients, the most important thing is that we have to think about what's happening in the anterior wall versus the posterior wall, and how, like, our initial observation of the patient is really the start of a prolapse examination. And what the anatomy is now leaning towards is not just, of course, the muscle function that we're so wired with in physical therapy, but also so much about the fascial support and the anatomy. So I like to think of, let's see, make sure you can see this. I don't have my, there we go. So there's that whole levator hiatus. I have probably a better slide of it. Let me share that. I can see that better too. Um, let's go here, share. I'm going to go back one. So what I see, or you can see, is that the hiatus is this opening, and this is looking from below and seeing this puborectalis. And I think that the most important thing that we have to remember about that is the puborectalis is actually more inferior than the rest of the levator ani. And you can never really see that on these three-dimensional pictures. So when we're talking about the anatomy of support, we're looking at this. It's actually a portal for hernias, right? It is a place where um, what is supposed to be in the body has an opportunity to exit, and it exits through the largest portion, which is called this whole levator hiatus, but it can also be broken up into what's called the genital hiatus, which is between the urethral meatus and then the posterior hymen, which you can't see in this above view or over in here, and I'll go into more detail about that. I want you to think about, like in a model like this, um, you can see that the puborectalis, or the most inferior muscle here, has been disrupted. So they talk a lot about the size of the levator hiatus when they talk about ultrasound and MRI, but obviously we don't have this in the clinic. So let's think about ways that we can assess or think about what is happening to this fascial support and muscle support that we are evaluating as part of the prolapse assessment. So I think the most important one, and I got another slide here, I think, yeah, is that a lot of people think about Delancey's levels of support, and they start from above. And so we have cardinal and uterosacral ligaments. They're more parietal ligaments. They attach to the outer bony complex, and also have a combination of fascial integrity in them. I think the mid-level of the vagina is really, really important to understand. And the arcus tendineus of the fascia pelvis, here, let's even use a little liner here. So when you look here at the arcus tendineus, it's the superior support, and this is a really common place for there to be fascial disruption. And I like to consider that when I'm looking at what the actual prolapse looks like. In the posterior region, it's the arcus tendineus of the rectovaginalis. These two fascial planes create sulci that actually, you can actually feel this sulcus and this sulcus if you are attuned to it in your internal palpation assessments. The other thing about this is that this fascia supports the vaginal canal in a way that it creates this elongated kind of, they say, H-shape tube. So the third level, or the lowest level, includes the pubovesical ligaments, the perineal membrane, the transverse perineum, all these muscular supports. So the muscle support, in some ways, in this surgical model of prolapse, is really only the inferior part, but it doesn't always think about what's happening with the levator ani and the puborectalis specifically. So,
So Kathe,
yeah.
when we're looking at this, for the sake of everybody, to just kind of keep it a little bit more into the comprehensive picture, the level 1 is the tissue supporting the uterus.
No, yes, level 1 is supporting the uterus.
Right.
Absolutely.
Level 2 is really that vaginal support system.
Vaginal support
That's
system.
keeping it into that H shape, and because the vagina is basically just a tube. It's not open all the time. It's kind of collapsed on itself unless it needs to be. And so you've got the special fascia that comes off of the arcus tendinous to support that, correct?
Right.
Right. And then the level 3 is what everybody's kind of used to looking at, is the urogenital triangle.
Right. And then I think it's really important to look how, let me go back to the little lines here. There's connection down here into the third level. And that here's that ischial spine, right? And the ATLA, which is going to go this way. Whoops, I went a little off too far there. I haven't used my little guy in a little while here. The ATLA is going to come down and go this way, and the arcus tendineus of the fascia pelvis is going to go more inferior and medial, and the ATLA is going to go superior and lateral. And that's where we start to think about what we can feel during an internal assessment. All right.
Perfect.
Yeah, thanks for the little summary of the components there.
I like the picture though, drawing the connections through there, because I think when people think of layers, they forget that those layers are connected. They're just
They
like, oh, we're
are,
working on
and
this layer. We can't do anything about this layer, but there's connections all the way through from top to bottom, side to side, and around the back and in the front, which is important to consider.
even, I mean, if I had to do it over when we started teaching pelvic floor exams early, we would call a layer 1 the most superficial, layer 2 and layer 3. And in technical terms, the puborectalis actually, because of its inferior and attachment to the perineal membrane, is really almost part of layer 2
Yeah.
at its insertion.
Hmm.
Or origin or attachment at the pubic
Hmm.
bone, depending on
Yep.
how you look at it. So that means that we can actually palpate those. Oops. I got my little guys on there. I'm going to get rid of them here. So what I want you to think about when you are doing an examination is that the ATLA over here, I'm trying to draw it here, right in here from the ischial spine, goes more superior and laterally. And the ATFP, which also comes off the ischial spine, oops. I promise I haven't had a morning cocktail, but I seem to be having a little issue with my little art guide today. Let me do it again. So it's also coming off the spine, but it's coming more medial and inferior like that. And so we are able to actually palpate these two structures to see the difference in our prolapse, because the arcus tendineus of the fascial pelvis is really where that second layer and all that vaginal support connect. And it's also a place, again, where that puborectalis connects, and we think about our levator and our genital hiatus and our levator hiatus, and whether that's been disrupted. So more specifically, being able to place our finger on the internal surface of the pubic bone and going inferior and medially versus laterally and superiorly. I think most people are used to going from the ischial spine to the insertion of the pubic bone, but a lot of people don't think of going from the ischial spine and going down to feel for the fascia pelvis down here. So I have a clip from one of my netter slides that really shows this pretty well, if I can get that to work too. And so what we're looking at is from above. We're looking at the bladder. And then what we are also looking at is all this vaginal fascial support of the ATFP, and then how much more lateral it is in the ATLA. So when we're placing our finger vaginally, here we are. Let's see, I got to get this right. And I'm going to be coming in. I can come up and in and start to feel the difference of the inferior versus the superior part where the HLA is. And this is going to affect this urethral levator gap, which is also part of the support mechanism.
I'm going to stop your share for just a minute. Go ahead and show that again on the model where everybody can see, because our picture is small when we have the slide up. This is brilliant. And I think this is a key piece of the exam that can really help all the practitioners out there.
Yeah, this is a model I got from Peter Dietz in a class I took, Canadian Augs course, and he was handing them out, and I'm like, oh, how many of those can I have, please? So again, what you're seeing is you're seeing that the levator it could detach on one side compared to the other, and that when we place our finger vaginally, we do not have to go very far in to get this puborectalis and ATFP insertion. But when we want to do the ATLA, we're going to be coming more superior and lateral. Does that show up pretty well there?
Yeah, shows up beautiful.
Yeah. So I love this model because it's a great teacher of of the avulsion or injuries that can occur, but also you need to consider that it's both the fascia and the muscle. It's not just always one or the other that's
Right.
going.
Right. And that's just the teardrop that you see on the opposite side when you were showing it is kind of like that hallmark look of a levator avulsion,
Right.
right? That they see there. So that model is fantastic.
It's a fun one. Yes. All right. So I really think that when we are focusing on where the fascia might be disrupted or where the muscle might be disrupted, we can start to look at what is descending down in a different way. Because if the ATFP, which is more lateral, is disrupted, it will look different than if there's disruption of the pubocervical, pubovesical, central fascia. So let's show a slide. Let's see here. I think I have one.
And I think a lot of times clinicians aren't used to the terminology of lateral and central. I think they're used to the terminology of anterior and vaginal vault and posterior.
Uh-huh.
And they're thinking about these. So this is like brilliant to be able to kind of show that central kind of, versus the lateral, we're really talking about the fascial support system.
Okay, I'm trying to progress my slide, but it's like not wanting to do that. That's interesting. I'll stop my share and start over.
Yeah, you can.
Come on. It's stuck.
The little arrows are down there. I think if you click on the little arrow, it'll come.
There we go. I'll do that. Thank you. I'll
You're
just do it now.
welcome.
Thank you. All
Mhm.
right. So this is what I was talking about. So a central defect is more of a urogynecologic term. And so in the central, the pubocervical, the pubovesical ligaments, there is more of a distension or a ballooning look. Because it's in the central area, it's a little bit more symmetrical as it descends. Now, the other thing that I want you to think about is that, of course, this graphic is with a half of a speculum, and that a lot of people learn to just put one finger in when they do a compress down on the posterior wall. And if you are really having someone that's nulliparous and you're looking for something like that, one finger might do. But really, two fingers or half a speculum is really going to allow you to visualize so much more than just using one finger. So there has been work that shows that, and as I started to observe and study this more, that the genital hiatus, again, from the urethral meatus to the posterior hymen, expands before the prolapse descends. So if you are evaluating this, it's important to consider how much does the hiatus actually open for it to come down and descend versus is something just coming down and going back up? There's this like kind of like, okay, there is a normal amount of movement of the anterior and posterior wall, but are we having this change in the hiatus along with this descent that we're asking for? Okay.
I think that's an excellent point, is that it really lengthens, it opens up, and then, is it doing that, or is it staying still, and is just the anterior and posterior walls moving forward and back? Because that's
Because, yeah, if you're getting someone functional and you see, well, actually their hiatus isn't changing that much, that's going to be a good sign for functional activity, I think, improvement. Now, this is all anecdotal at this point and lots
Mhm.
of experience, but um, there's so much more to this evaluation that's so functional compared to just looking at positioning. Um, I'm going on and on about that
That's
with you
okay. It's all
today.
right, because
Um,
what does this mean when you see this? Like, that's what we're trying to do here, is like, what does this mean, and how is that gonna translate into what the person can do safely
right.
or with less
So,
risk?
is the hiatus actually opening a lot or is it not? Okay. And then it's descended because the pubovesical and cervical ligaments are going to support the rugae. Rugae are the natural ridges within the vaginal canal. So when we look over here on the lateral defect, we're thinking about things in the mid vagina, usually at the area of the ATFP. And we are going to see that there are rugae because the central part is not as disrupted. The thing that caught my eye the first time was the asymmetry of this rugae or the support. So, does that asymmetry match the muscle asymmetry on each side? These are very important things to consider. Usually, the answer is yes. It sometimes is not asymmetrical if there is a bilateral defect in the ATFP, but you will still see the rugae. Okay. And once again, as we ask for a strain or bear down, and I'll go into that in a little bit, are we seeing a lengthening of the genital hiatus before the descent, or is it staying the same? Yeah. So I really find that understanding the ballooning you will actually place your finger vaginally and you can feel this um, softness. Whereas when you place your finger vaginally in the lateral defect, you can actually feel the ridges, but it doesn't feel, I guess, so full of air or or lost or lax as the one that's from the pubocervical and pubovesical central ligaments. So that now clinically, the biggest difference is that sometimes pessaries are much harder to fit in people that have defects in the mid-vaginal canal. Or my experience with patients that were fit with them was that they would fall out easier or have more difficulty with them. I'll get into a couple more things that will affect whether a patient should have a pessary or not as well. Okay. So, what's next? What else should we talk about?
Let's see. Okay. So, you've talked a little bit about a levator ani injury, and you talked a little bit about the exam, looking at the various fascial supports there. Is there anything else? And the little teardrop, there's that external exam where you can kind of see that little teardrop that happens one side versus the other. Is there anything else particularly in that exam clinical test that may be helpful for people to know? And if there is a levator ani injury, what are we doing now? Because I
Yeah,
know that surgery hasn't been they
no.
haven't been able to create a surgical intervention worthy of this yet. So kind of, and I know that that's kind of one of the things. It's like, oh, they have a levator ani injury. What do I do? I don't do anything. What happens? So,
Right. Well, and then even so there's two categories of levator ani injuries. There's more uh, um, micro trauma where there's ballooning or herniation. And, the studies are all done with real-time ultrasound or MRI. And
mhm,
in the greater Seattle area, there are there's like no one really doing this kind of work. Now the question is, how soon are you seeing them? If you're doing an immediate postpartum evaluation, it
mhm,
is way too early to start telling people what is injury, what is dissension, what is micro trauma, what is macro trauma, unless they have an obstetric anal sphincter injury. They need to be seen and dealt with really early.
right,
There's good research on that.
mhm,
But I actually personally asked Dr. Dietz when I was with him, I said, when do you think is the best time to do an assessment that will tell us more about function? And he said he likes to wait till the fourth trimester or thinking about it. Now, that is all relative to the patient's perspective, but there is so much healing. 50% of like a minor tear and even some macro traumas improve over
mhm.
time, over in a year. So we don't want to wind up getting a fear-based response out of our clientele.
Yes, yes. Let's don't give them something they don't have yet.
Right.
That they're gonna incessantly hypervigilantly worry about. But I love that because that speaks back to the things that we already know, the physiology of tissue healing, and that we need to respect that. In the first couple of weeks, we've got the stage 1 healing where things
Right.
need to like knit and stitch together and, hook together and do their thing. And then, we move into phase 2, which can take weeks, for that to work. And that's where collagen repair comes in and really starts to strengthen up. And so this is why movement is important because we're not going to get collagen blast going if we don't have some movement to the area.
Well, blood flow is good, yes.
Exactly, exactly, 100%, and some neural activity and all the other pieces. But I love that because it's like we don't know in the beginning. We've got swelling, we've got inflammation, we've got boggy tissue. We've got all kinds of things going on in there, after this normal physiological event that's taken place. And yeah, I love that because we really do need to wait and see, and then really have that investigated appropriately if
Right.
possible.
I also think that we spend a lot of time seeing, or my initial way that I looked at it is, well, what's coming out and how far is it? And then it's like, but wait, what can you change that with a breath? Can you change that with a pelvic floor contraction? Can
Mm.
you change that with the position that you're holding your pelvis in? And so it's not so much about what the grade is. Everybody wants a good grade. I haven't met anybody, well, all my friends at least, right? Everybody wants a good grade, but it's like, does that grade change if I use the muscle? I mean, I've mentioned this to several urogynes and things. It's like, well, do you ask for a contraction after the prolapse to see if it improves? And they're like, you know, why would I do
Yeah.
that?
It's a ligament thing. Why would I do that? Yeah, it's because
Right, right.
under what condition are they prolapsing, I believe is what you're trying to get at.
Exactly. Exactly.
And what are the possible conditions, which is our purview, is it, and to your point about how the pelvis is being held in the body, if they're standing on their heels, which is a typical postpartum thing to do with a wider base of support, They're holding their baby up on their chest,
Right.
and their belly muscles are long because they've been growing this way for 9 months. They're not going to retract in a week. you
No.
know what's working and not working, and under what conditions. And then you add a cough, you add a sneeze, you add laughing and talking and lifting and moving the baby in and out. And like, what is it that we can do to optimize the system
So the
during
question is, yeah, or the way I look at it is it's probably better to work on that patient's posture and how they're holding the baby and all those things and, understand what the pelvic floor does, but not give them, so many repetitions per day and
Mhm.
because, and then does it have to be a maximum contraction or a sub-maximal contraction? And I mean, we could get so lost up and tied up in our exercise regimens rather than our functional regimens. So I'm trying to think of it functionally.
Mhm.
Yeah.
Yeah, the capacity of the muscle is good to consider for sure. But again, it makes me kind of wonder, in the very beginning, is it the most appropriate thing to be like leveling on lots and lots of repetitions on tissue that's actually working through the healing processes? Yes, but getting up and doing breathing differently and moving differently is also going to have influence. In that muscle has to be brought into the system functionally, not just isolated, in order to like optimize, what happens with coughing, sneezing, laughing, running,
Mhm.
jumping, climbing trees. Because many of these women are not just having one baby; they're having many children. And so, there's always two toddlers and somebody who's jumping and running that they have to jump and run after, even though it might be more immediate postpartum. So,
That's pretty funny. That's very true. I mean, again, we're on the same wavelength, and
yeah,
I think we just want to impart that to um, the uh, the surgeon or the physician who's sending them, because a lot of times the patient's asking more than sometimes they're being sent these days,
yeah.
depending on where you live and what's going on. Um, it kind of takes me into like, are we doing a prolapse exam like the pop Q exam? I mean, the pop Q exam is a quantification of position of the organs so that physicians can talk between International Continence Society, the Urogynecologic Society, and all these other people. If you say this, that means this. So it's all about position and anatomy. And when I think about what a holistic or more holistic way to look at it is that a rehab kind of approach is it's about what can we do to support it and how well does it actually function. I mean, those are like, like what function? it's it it's not in some some of the physicians' wheelhouse. I mean, it
Right,
really
right.
isn't. It really isn't.
Yeah, they're not. That's not their thing. That's our thing.
Right.
We're there to do this part, and the more we can communicate what we see, how this is changing, what when they do this, this does this. When they do this, this does this, and we can help keep the conversation going. Then that could actually guide. Okay, maybe a pessary for this person, which would have never been considered for 10 years ago. If you had sent somebody, I can even remember 20 years ago, trying to send somebody who just needs like a pessary, like a little bit of an orthotic, just a support, so they can do the things that they want to do, because they're not going to have some big giant surgery until they're all through having children. And then only if you can convince them that it's really better to like take care of this now and not when you're 75. Uh, but just and being able to communicate that, so that I think the physicians and surgeons can support rehab a little bit better too, would be nice. But we want to, so you do a pop Q exam, you get the numbers. We do the pelvic floor exam, the pelvic internal pelvic exam, not just the pelvic floor. We find where things are not shored up as well. We find where we kind of see that the GH is like expanding before we see a presentation. We either have rugae or we don't.
Those things are
And yeah, and it's been 6 months and we've done all of our work, and yet they still have, everything is better, but they still have that levator ani injury. What happens? Is there anything to support it, or do we just keep optimizing the system as best as possible?
my experience has been optimizing the system. Dietz himself again said that there's no really good surgery, and also understanding the so that the patient has an understanding that there's lots of function that can occur. I think that can kind of get into some functional exam things that we can talk about. And I wanted to kind of show like, or talk about, well, I want to show you one thing about the pop cue and the staging, because I have a little graphic I did when I
Okay.
was in the
Yeah, then I think
COVID.
people will be very interested to kind of know like what the clinical considerations are, with the other part, for sure.
Okay, so again, when we tell patients they have a stage versus a grade, that can help them maybe not feel like A, B, C, D, E, or F. But the stages are relative again to the hymen. So when we're looking here, it's really, the hymen right here, it's 0. Is it inside the body or outside, going to the labia majora and then out? So if you look at this, you have to remember that if you say it's a grade 2 or stage 2 would be the technically correct way to do that. In the POPQ system, do you see that stage 1 is only 1 centimeter, but stage 2 is 2 centimeters? One of them is above, 1 centimeter is above the hymen and one is below. So you can have a 1 centimeter change either way and still be in stage 2. So there is a move for you to document, is it stage 2 at the hymen? Is it stage 2A above? Or is it stage 2B below? Because I can go from a stage 2B to a stage 2A and still be a stage 2. And that confuses the patient. They're not going to feel like they're getting any progress. And a centimeter isn't that large, but the data shows that sometimes people have more symptoms when the prolapse is actually internal in 2A than they do in 2B. And I think that has to do with the sensations of the vaginal vault, but it varies on studies with that.
I think that's so interesting, because I was just going to say it's kind of like when you have something sitting in the rectum versus something sitting on the top of the anal canal. You're going to be way more symptomatic when something's touching the anal canal, with a lot more kind of feelings than just the rectum, because the rectum's only going to give you pressure, but the vaginal canal has different areas and zones of sensation as well. And yeah, that right up into the internal, just above or inside from the hymen, it's that zone in there that can be quite sensitive
Mm-hmm.
to a lot of different things. It's one of the primary areas where people feel, the pain with, or in and around the hymen, and just those tissues right there at that, the introitus insertion part, not the deep part, with vaginal pain. So interesting.
Yeah. And I think the takeaway message for clinicians is please delineate a grade 2, or just at least say it's above the hymen or below the hymen so that you can go back and remember what you're seeing. And really there is, progress for the patient. And usually, it depends on pain levels with this or what the largest symptom bother is. If it's heaviness and seeing that they're having a descent of the anterior wall or the posterior wall, then they're going to feel better when they don't see it when it's inside. But if they're having sensation changes, it may actually feel different when it's internal. So there's that's where we have to consider um, really helping the people with, can I change it from a 2B to 2A with a pelvic floor contraction? Can I do that by changing the tilt of the pelvis in certain positions? And this is going to happen in supine, and it's going to happen in standing. The other thing I just want to point out about this model here is that, again, there's so much surgical bias is that they've got 1, 2, 3, 4, 5, 6, 7 different stages that it could be in stage 3, because this is where we're talking about surgery and wanting it to go back up into the body. And so stage 4 just means it's completely, this is when we're talking about the uterus, completely out of the body. But we can also look at, the differences is one wall compared to the other. So let me see if I can show you that as well. Let's see here. And then let's go here. So I just, this is the grid system. And again, this is the GH and the PB. And I just like to emphasize the fact that in a POPQ grading system, there is a stable point, and everything is relative to this point AA that is 3 centimeters inside, and point AP, which is the posterior part, which is also 3 centimeters inside. But it's actually looking at what's happening along the mid-vaginal vault here in the anterior part and in the posterior part. And so if you look at this graphic here, point A and the anterior and point B, this is all anterior wall, and C is the cervix. D is the longest part of the posterior vaginal canal. So all this can prolapse down. And in this example, the anterior wall is well supported, but the posterior wall has positive readings. In this particular example right here, there has been a hysterectomy, so they don't measure the level D. Okay. But the reason why I wanted to bring this up is just that I think it's important to really understand this. When I do my full class, I have quite a bit on what's going on so that you can talk to surgeons and physicians. But when we're looking at it, I really want us to think about it really about what's happening with the standing postures. And you were just talking about this posterior
Yep.
position.
And there we go. I love it. There you are.
There we have it.
Lining them up just a little bit differently, helping their whole system. And the interesting thing about this is that they stand the way that they do on the left, because during pregnancy, if they don't, they're going to fall over. Right? Anterior posterior sway is the biggest risk for fall in the 3rd trimester. When they have their baby, though, their vestibular system is still set for them to be in that other position. And the work that you're doing here is helping them begin to feel their body, and that's going to help reset their vestibular gain back to where it belongs, over the feet, not back on the heels. But yeah, and so how, prolapse examination, standing or not?
Let's come out of here and talk a little bit. I just wanted
Yeah,
to show this because
I
I mean,
know that's
the
going to be a very
patient
interesting.
perceives themselves as being aligned and not being able to feel their pelvic floor. And I go and I just help them with their positioning. And all of a sudden, we are golden, you know?
Mhm.
So, what I think is important is to break down what are you really trying to do with a standing exam? A lot of times, a patient says, well, it doesn't come down as far right now. It only happens when I'm doing blank. And then, automatically like, well, let's look at blank, right?
Exactly. That's me.
It
Show
only
me.
happens when I lift my groceries. It only happens when I do this. Now, there was one study that showed that if you actually have somebody strain for 8 seconds, you're probably going to get a maximal descent. Now, that's a really long time. And if we really just want to know how far it's going, we could do that in a supine position. I tend to use a balloon a lot. I use a balloon to simulate strain because if I say bear down or push,
Mhm.
there's this automatic, like, I don't want to do that. So I just have them, I make sure the balloon is brand new and really hard to fill up and have them purse their lips around it and blow out. And there'll be an automatic, normally 90% of the chance, there'll be a descent of the pelvic floor with this balloon blowing behavior. And so we can see that in supine and we can compare it to standing. Okay. Now, the real question is, are you observing only? Do you have the patient standing and you are actually up underneath looking? Do you get a mirror with a long handle and widen their legs apart into abduction and then just look together with the patient to see, yes, it is descending more. And then I immediately say, let's change your posture. Let's try a breath. Let's direct your breath downward versus upward. These
Mhm.
sorts of things can make a huge difference. So observing it, I like to use a mirror together because I'm not, I mean, I can verify that it is lower in an upright position, but what can I change about that upright position? What can the patient learn about that upright position that can really help them feel better about what they're doing? I think that's really a key
I
factor.
love that. And I think it also it just is more practical, so if we think along the terms of biofeedback, I mean, the mirror is biofeedback. They
It
get to see it. They get to see the change. They don't
is.
have to take your word for it. And I think sometimes for a lot of people who are a bit hypervigilant about this, when they say a picture's worth 1,000 words, it really truly is. Like, look, it's different. This
Right,
is what you're looking at. This is what you're seeing. This is how quickly it can change,
right.
which is like, oh, like I can do something right now and make it better.
Exactly, exactly,
Mhm.
exactly. Um, there are times when palpation, I don't know if you've ever, I put a glove on, I'm going to show you something. It's like, I'm like, oh, um, there are, excuse me. There are times when I think palpation is indicated. Sometimes when you're placing your finger as a screen and you can feel pressure both anterior and posteriorly, you
Mhm.
might want to see in an upright position, is it really happening more in the posterior compartment or the anterior compartment? And I think that's helpful to for sensation awareness. A lot of times rectoceles are a lot more bothersome in my
Mhm.
personal clinical experience. Um, and and I want to see if that's actually what's happening. So I'm going to use this like tube here and I'm going to place my fingers vaginally and I can do it on like the anterior wall or the posterior, or this would be the anterior wall and this would be the posterior wall. Or I could actually split my fingers when I had them in there. Okay. And usually what I do, that way I can tell, is it actually happening more on the posterior wall or more on the anterior wall? And then that might make me give them more cues for the puborectalis, more support in the posterior region as far as their exercise program as well. But it will help me understand what they're feeling the most. I think that when you ask again in that position, can you change? I like to have the patient separate their labia for me. And then I do have to go down and look. And this is where a lot of people are like, what are you doing? And why are you doing this? And I gotta tell you that the first couple times I did it, the patient thought it was so helpful that I got over this idea that I usually would wear goggles. I would get underneath. I'd need to put a chuck pad down. I decided, well, if I put their foot up on a stool, they're going to be into posterior tilt. So I have to take that into account and ask for more anterior tilt for contractions and things like that. I've tried the split lunge position. That one's really hard to see anything. So it's usually
And it's good for
abducted.
people to do.
It's good for them to do, but if we can't, it's really hard to observe, but we can feel in the split lunge position,
Mhm,
or we can feel in a functional kind of position, even with the squat. Or what
mhm,
if you contract, or what if you gently purse your lips? What if you hum a little bit? All these things can change what it feels like to the client. And I think that's what's really important. So when I break down the functional assessment, I like to think of it as, am I really going to observe what's going on? And when is palpation the most important? And observing really helps when the patient can see it, but it's our observation of all their movement patterns that I think is so important. Like, how are you doing that squat? What are you doing? How are you breathing? I've been fortunate enough to take some Institute of Physical Art courses, and the Johnsons have this vertical compression test, and it's one of my favorite overall tests for somebody standing. I showed you the postural change that I did with the person, but a vertical compression test, we'll leave some notes for the people, and I cover it completely in my Prolapse course, and is some vertical compression, seeing where do they go into posterior tilt, do they go into anterior tilt, what part of their anatomical support in their torso is not working, are they so posterior that their diaphragm really isn't going to be able to function well. And that compression is like, this is like every jogging step you're taking. It's like, this is what's happening through your system, and the eyes get really big and the attention gets really strong. And the clients is like, oh, I get it.
mhm.
It's really important.
Right.
And the
We've got
other
it. We
thing,
issue and the here, and the prolapse is here in this position, and now you're loading it,
right,
right? And what we're trying to do here is get them into a different position where it improves, and then load that.
right.
It's no
Kind of
different.
driving with your wheels in alignment versus
Yeah,
out of alignment,
yeah.
right?
Where's their center of mass? Is it way off? And they're loading that, and that's every step they take,
And
every step
that
they take.
so much helps the subjective symptoms. It really, really does.
Yeah, that's great. I've always called it the fourth plane of motion for the core, because
Uh-huh.
we never consider the up and down. We consider sagittal and coronal and transverse. But what
That's a
about
good
the up
thing.
and down?
Yeah. Yeah.
And that up and down piece is so important. I think from anybody, whether they have prolapse or neck pain or foot pain or knee issues or hip issues, that test is like, it's just really golden to help people understand where they meet them where they are, load them up and see what happens.
Right.
Like, and this is what's happening every time you take a step, like you said, or every time you run, or every time you get onto your feet and straighten up, boom, there it is again.
Yeah. It's, um, it's very functional. It's very, very
Yeah.
functional. Yes.
Mhm.
And then I think the other thing that I would really like, probably the last thing we could talk about is just, if it's really with lifting groceries, give them a load in their hands and observe their neuromuscular response. Do they immediately go into breath holding?
Yeah.
Um, and then sometimes with the load palpating, you can actually feel a balloon on one, it's like, it's almost like the breath holding and the inner abdominal pressure creates more of that balloon. And then redirecting them how to hold their breath when they're, or not bearing down or straining,
Mhm.
changes their perception of what's going on. So it's that, loading them with like groceries and seeing if they're activating their core, staying in that good fourth plane or not.
Mhm.
They like that too. That's
Mhm. Yeah, these are some great, great, great expansions on clinical evaluation, but also moving straight into clinical work like the interventions. You take it from the evaluation and immediately you apply the intervention. And you can do it on the table supine, you can do it with them in all of these functional positions as you talked about, but in ways that's really going to up what I like to think about is when the client can internally begin to make the change based on what they're learning. There's an intrinsic shift, and that's from interoception. They're able to kind of like, I can feel that my body is doing something different.
exactly
And when we can get the intrinsic piece to come on, they're going to be more empowered to make the change because it's motivating to their brain to look for that sensory, that new thing. Like, I want to get back there. I want to get back there. I want to get back there. There's a motivation. It's relevant. It's safe, and it's something they can do consistency, which are the three things that I talk about all the time. If we want to help our clients move the needle forward in the direction they want to go, they need to be able to be, it needs to be relevant, it needs to be safe for them, and it needs to be able to be done consistently.
right.
And you hit all of those marks beautifully here with this. I love all of this. I especially love the whole idea and the talking about the standing exam, both from an assessment and some various ideas from assessment to right into intervention and really helping the client move forward.
Yeah,
Um,
it's
this
yes,
is
it's
this
a
is an
one time.
hour of gold.
Great. Well, I went to UCLA and John Wooden was the basketball coach, which tells you how old I am. But he used to say, "It's not what you do; it's how you do it."
Yeah,
And I think that's something that I really, if somebody says that that bothers them, it's always like, "Mm, show me what you're doing." I mean, from splinting to hands and knees sexual activity. What are they doing? How are
exactly.
they actually doing it? So it it's the whole realm of our care, I think. Yeah.
Beautiful. Kathy, before we say goodbye, can you please tell people how they can get in touch with you and tell us a little bit about your course?
Ah, well, I developed pelvic floor support systems for prolapse pain and postpartum recovery because I really felt that understanding the anatomy and understanding more detailed examinations will help us drive our treatment. And also talking more about pressure, posture, pulls, and performance, which is another course that I'm currently have online, and you can find them on my website, kathewallace.com. I also, please, 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 I have a newsletter. I would love you to join. I have tons of resources. I have worked with independent study students, like I said, and we have a whole bunch of literature reviews. We have one on pessaries, we have one on inner abdominal pressure, and All these things are there to access for your growth and learning.
And the link to join the newsletter is in your show notes, along with how to reach Kathe and how to find her courses. And anything else you would like to add before we bid you adieu? And thank you so very much for your time.
Um, I think that just keep remembering that this is a lifelong learning process. I mean, how many years have I been doing this? And I just never know it all.
Right.
And and I think that as long as you keep an open mind and keep learning and keep trying new things, you're a golden therapist. I think that's really important to remember.
Yep,
And
you're exactly where you need to be, and the opportunity to learn happens with the client that stands right in front of you every day.
yep,
So,
yep, yeah.
thank you so much for your time, your curiosity, your development of this work, and just really sharing your functional assessments and interventions with everybody. It's going to help grow their practice, and we're all going to be better for it. Thank you so much, Kathe.
Oh, you're welcome. Thanks for inviting me. Have a good day, Susan.